I am Kostas Hadjipanayis. I'm currently at Mount Sinai. I'm going to talk to you a little bit about 5-ALA. Here are my disclosures. I did receive royalties for 5-ALA before, not now, and I am a consultant for Hamarion and these other companies. Okay, so I don't think we need to talk too much about high-grade gliomas and the unmet need that we all deal with. We're going to touch on fluorescence-guided surgery, a little bit of the history behind it and kind of where it's going, and then talk about a newer concept based on an older concept called photodynamic therapy and a study that we're going to launch hopefully this year. So, I think the standard of care is pretty well written for us in terms of high-grade gliomas. We all want to take out as much of the tumor as possible. And we know that a maximal extent of resection will make a difference. And I think it's been, debated, it's controversial, but we all want to take out as much of the tumor as possible. And outcomes do improve with maximal extent of resection, whether it's minimally invasive, maximally invasive, whatever you want to do. And of course, that helps with adjuvant therapies. The challenge is that our paradigm that we use is really outdated. I mean, we're using a paradigm that's outlining a tumor based on the blood-brain barrier. As you see here, we want to take out the contrast-enhancing tumor, right? And we all feel great about that at the end of the surgery. But the problem is that enough, right? And there's new papers coming out supporting, resecting more of the non-enhancing tumor. And then, a case like this where we can't do any resection, how do we treat these types of tumors in the brainstem in children that die in 6 to 12 months? So we need better answers to these. And, part of our challenges is the biology. So, studying in our labs and trying to develop targeted therapies for these tumors is great. But as we heard today, these are heterogeneous tumors. Cells extend past the contrast enhancing border. You see these red, dots. So how do we kind of get to that area better? There's no perfect answer, right? How do we get to it better in a safe way and really kind of put a dent in these diseases? So fluorescence-guided surgery has been around for decades. I mean, this is not a new concept. In fact, in the late 40s, there was a publication on fluorescein that was used where it was used to localize a tumor. And then, of course, there was decades after that nothing happened. And then Walter Stummer kind of brought it back to life in the late 90s. And it's really just based on a very simple concept, using a fluorophore or a prodrug, in the case of ALA, that accumulates in the tumor, and then exciting that fluorophore to really get that fluorescence visualization. And Walter really showed it to us. I mean, his landmark phase 3 study really showed better, more complete resections, better progression-free survival. You don't need image guidance once you see the tumor with fluorescence-guided surgery. You have a real-time image-guided view of the tumor, and it's independent of brain shift and neuronavigation. And then arguably, can it help with a safer resection when you combine it with other adjuvants that we do routinely in the OR with direct cortical and subcortical mapping, and then for language purposes, awake craniotomies. So, this is something that we now have incorporated into our practices. I mean, I'd say it's a standard of care now. I mean, I think it's a tool that we use, one of many tools that we use that help us visualize tumor. And as was mentioned earlier by Zach, it's an agent that the patient drinks, it accumulates in the tumor, it's metabolized to the metabolite that fluoresces. So there's no mistaking the tumor, unlike some of the other fluorophores that are out there. And it's a pretty safe drug. It's been used in thousands of people. And it's really skin photosensitivity is kind of the thing we talk about in about 10 to 15% of patients. So, we learned from a number of studies how diagnostic 5-ALA is. So we were able to complete the first multi-center study. This was just published in the JNS this past year. And again, it confirmed that if you see fluorescence, it correlates with tumor. There's really no deciding factor that it's non-diagnostic for tumor. And this was a study that we did in 15 sites in the US, and we did it in newly diagnosed and recurrent GBM patients. And we also found that it was safe. And it's another study to kind of add to what was done by the Europeans. It's really our US experience that helped us define this better. And you could see the numbers here are quite astonishing. I mean, a sensitivity of 96.5% in a multi-center study was pretty good. And of course, the PPV was equally high. Now, what it wasn't good at is the specificity and the negative predictive value. And why is that? Well, that's because of the infiltrative biology of the tumor. So if you go back to that first slide I showed you, those cells that are out there in the periphery, we don't see with our eye fluorescence. And the only way we could see those cells is if we have more sophisticated visualization devices, which are coming along slowly. So when we did this study, when you get out into the margin, even though there's tumor there, you can't see the fluorescence with the microscope. And I think that's one of the biggest challenges. So that's why the NPV and the specificity traditionally have been lower. Okay, so I like showing this slide because it puts everything in perspective. So we spent years working on 5-ALA to come to this country, and there was a lot of back work being done. And of course, Walter was the one who started this in the world. And he started this in Germany in 1998. And of course, his randomized study in 2006 really heralded fluorescence-guided surgery forward. And then we went to the FDA with all this data through the years and trying to convince them and how to get this through. And we finally got it to the finish line in 2017, and the rest is history, right? We now have it since 2018 marketed in a number of centers that you all are using. So where is it now? Well, it's approved for, high-grade gliomas. There are studies being done for meningiomas, and I anticipate that'll be another indication soon. And then, of course, there's other types of tumors that it's been documented in fluorescence, including brain metastases, not as robust as high-grade gliomas. And then what we're going to talk about is, we went to the FDA kind of arguing its diagnostic strengths, but now we're gearing up to say, well, it's actually a therapeutic too. If you shine a specific wavelength of light, you could kill cancer cells with it. This is a cool slide. So we had the first head and neck cancer study with 5-ALA initiated at Mount Sinai Hospital. So this was the first patient that was done, robustly fluorescent head and neck cancers. And you can imagine, like, for recurrent tumors, how effective that could be in terms of margins and other types of approaches that our colleagues use in the OR. The only challenge is they don't like using the microscope. So the headlamp that's now come out, that time we were able to get a couple of the new design for vision headlamps, and they love them, because that's how they take out these tumors. So a couple, caveats and things we've learned through the years that not only the Europeans have taught us, but we also have confirmed, is that with fluorescence-guided surgery, the longer you wait, the fluorescence works better. So, the problem is if you do things too early, the fluorescence isn't as robust. So, we've done cases 12 hours, 14 hours, and even at Henry Ford, our colleagues did it 24 hours in our multi-center study, and the tumor still fluoresced quite well with 5-ALA. So the window of treatment with the FDA was 2 to 4 hours, and we usually give it 3 hours. But honestly, if you wait longer than that, it'll work better. Now, it becomes a little problematic if you wait too long because you got to operate at some point during the day. But if your patient's admitted overnight, then you give it to them at 3 in the morning. And this is just a paper that we published on that last year. And this is that 24-hour case you could see here at Henry Ford. My colleagues were kind enough to give me the picture here showing the fluorescence. So there's a bunch of technologies that are now being developed, evolving around fluorescence. This is multispectral imaging, where you overlay the fluorescence on a white light image with a microscope. This is published out of Germany. And then, of course, the visualization technologies that are coming forward are mind-boggling. I mean, there are some really cool stuff that you're going to see probably in the next 2 to 3 years. I mean, we have some of that here today. I mean, there's handheld devices where there will be a blue light. You'll be able to kind of visualize potentially the tumor better. There are technologies that will be able to classify and give you a number for fluorescence, and hopefully you could detect fluorescence in low grades. And we could use those technologies to move forward. And then, of course, you have the exoscopes, which will be much better fluorescent visualization devices just by how they're designed. Remember, the microscope is at a disadvantage because of how the light is channeled through the microscope. The observer hardly ever sees the fluorescence you see because of how much degradation occurs. You don't have that with the exoscope. They're able to get past all that, and it's a digital image. So you can see how much more powerful fluorescence visualization is going to be. Okay, just a few more slides. So this is, a low-grade study that was published by my colleague, George Vidhelm. He was at UCSF. He did a your fellowship with Mitch, and he used a handheld device to show PP9 fluorescence in low-grade gliomas. So I think this is where we're heading for those types of tumors. Now, switching gears a little bit, I think this is the area that I find is quite intriguing and promising. And, while we use 5-ALA for fluorescence-guided surgery, we now have an opportunity to kind of flip its properties and use it as a therapeutic. So we're all going to, we take patients to the OR, we do our maximal resection with fluorescence-guided surgery. Well, now there's some data showing that you can actually use that 5-ALA you gave for your FGS as a method to actually treat the tumor. So how does that work? Well, if you use a 635 nanometer wavelength laser light, you excite the PP9. Well, it so happens that you generate reactive oxygen species. Okay, so ROS species can kill cancer cells, very well documented. You could kill vasculature in the tumor. You could create an immune response. So there's an immune modulatory effect that actually can last quite a long time that's currently being studied. So the other area that I'm not going to talk about today is sonodynamic therapy, which is also enrolling. And that's using low intensity focused ultrasound in patients pretreated with 5-ALA, also to target the tumor. Think about that just for a little bit. You give someone 5-ALA, it accumulates in the tumor, and then you use low intensity focused ultrasound with no incision, right? So let's see where that goes. So this is just a cute little video here showing PDT and kind of the ROS effect on the cancer cell. And why is this kind of intriguing? Well, remember, 5-ALA localizes in the tumor cell. We don't have any agent right now that can accumulate in tumor cells as well as 5-ALA. You guys can quote me on that. And I have a lab and I do a lot of different research, and it is quite effective in getting into tumors. It's quite effective in localizing into the cancer cells. We have an opportunity here to really try to take care of the tumors in an interesting way. So here are some of the other ways to think about PDT. And remember, PDT was studied in GBM years ago with porphyrin, and it failed miserably. It was a non-targeting agent. There was tons of cytotoxicity. There was a randomized study done, and it never really went anywhere. So, the question is, how effective can this be in our GBM patients? Some of the early studies were done out of Germany, and this is a paper that was published recently where Walter and his group laid interstitial laser fibers in the resection cavity. Now, this was kind of an early attempt at PDT, and you would probably wonder, well, where did he put the fibers? Kind of blindly putting them in the cavity edge. They used, 2 fibers per patient, and then they did the PDT for 60 minutes. So it's a little bit of a crude approach, but it was an initial approach that showed some promise. There's been some other approaches called interstitial PDT, where you stereotactically place the laser fiber. You could put 6, 8, whatever, through little burr holes. Think about the ROSA implantation of deep electrodes for epilepsy. That same concept, and then you do the PDT, and that's been done in Munich in Germany. There's no publication for outcomes yet in those patients. There's been some preclinical studies, kind of looking at the effect on, rodent GBM models, where you could look at light dose and the anti-tumor effect. And it so happens that if you separate the light dose and you fractionate it, okay? So think about radiation, how we fractionate the dose. It's a little bit different here. It's not radiation, but you separate the dose. It seems like the effect is better. So the light goes on for a certain amount of time. You stop the light. You allow for reoxygenation to occur because free radicals form with oxygen. So if you turn the light on, you do the PDT, you turn the light off, you allow for oxygen to come back in, you're generating more and more free radicals. So that's the concept here in terms of killing the tumor better. Of course, with this approach, there's a possibility of cerebral edema. So the fractionation scheme also helps with that. And this was in a rodent study that was published. But there's a lot more work that needs to be done here. Okay, so what are the limitations? Well, the light penetrates only a certain amount, okay? It's, 635 nanometers of light is not near infrared. So you're probably going to penetrate a centimeter or so. So that's a limitation, right? We know that GBM cells go out centimeters away from the tumor edge. So that's something where the near infrared agent could potentially target. So that's one of the limitations from the beginning. The other concept is, how does this work with other therapies? And what type of immune effect does this have as well? So a recent study was just published. I was part of with the French group at the University of Lille, and they took the approach of doing fluorescence-guided surgery. They had intraoperative MRI, so they confirmed maximal resection of the tumor. And then what they did was put a balloon in the cavity, inflate it, and then do their intraoperative PDT. So here's kind of the concept here. So you take out the tumor and you put in this balloon, and I got a video here. Hopefully it'll show up here. Here it goes. So you inflate the balloon, okay, in your cavity. And then you illuminate the cavity with the laser fiber going through the balloon for about 30 minutes. In the patient who was pre-treated with 5-ALA that you did your FGS with, okay? So this was done in newly diagnosed patients, 10 patients. It was a feasibility study. We just published this last year and looked at it in combination with the stoop regimen. So all the patients got the stoop regimen. They got the 5-ALA FGS and 5-ALA PDT. This is a video of one of the cases. Nicholas Rains is the neurosurgeon who led this. And you can see they're all wearing goggles in the OR, and they're doing their illumination of the cavity. Okay, so this was done, and the trial accrued in 2018, and the patients were followed for 40 months, okay? 10 patients. So the endpoint was really feasibility, looking at safety, because this is really the first time this type of intraoperative PDT with a balloon treatment was performed. And then, of course, the secondary endpoints, PFS, overall survival, quality of life were done, and they have MRI data because they got intraoperative MRI after the initial resection, and the patients got another MRI scan if there was residual and they had to go back. So they're looking at some biomarkers. So here are the results. So the majority of these, just as expected, were unmethylated tumors. And we know unmethylated tumors patients typically do worse. And the additional surgery time was about 33 minutes, okay? The illumination time, as you could see, had a range of 417 to 980 seconds that were separated into 5 fractions. So they had 5 fractions of light. This was at 200 joules, so that was the light dose. And you could see that 6 patients in that period died, okay? 3 of them are recurrence in the operative field, and 4 are still being monitored. So 40% are still alive. And this was done in 2018. Here are the SAEs. I got this slide actually from the company because I wanted to really dig deep here and understand, because they told me they felt there were no SAEs related to the PDT. So as I look through this, one patient had a skin reaction to Bactrim. One patient had AFib. Okay, so one patient had some fluid drainage from the wound, didn't require an OR, didn't require antibiotics, and they were fine. One patient did have a superficial cellulitis that did require antibiotics, did not require an IND. And then the rest you could see here, one patient had a glial recurrence presented with status, and then another person developed aplasia of the bone marrow. The recurrences in the 4 patients, the patients who were recurrence-free currently are 4, we talked about, 40%. So 3 of them are methylated, 1 is unmethylated. And you can see here that we have patient 6 free of recurrence, 55 months. Again, this is 10 patients. I don't want to put too much weight here, but I do want to show that there's something going on here. Patient 6 free of recurrence after 55 months, 7 free of recurrence at 53 months, and then patient 10 free of recurrence at 49 months. Patient 9 had a recurrence at 16 months, had a second surgery, and then they placed glial wafers, and he's now alive 52 months. So that one, I don't know. I wouldn't characterize that as a but they include it that way. So I think, when you look at the numbers here in 10 patients, again, I'm cautiously optimistic here, you could see that the median PFS is 17.1 months. So if you look at the NovoCure TTF study that was published in JAMA 2015, it was 7 months for newly diagnosed GBM with the stoop regimen, okay? So it's about 10 months more. And then if you look at the overall survival, it's 23.1 months. So, I think this is something that is quite interesting. I'm just going to show a few examples here. This is a 70-year-old unmethylated patient who has all the poor prognostic markers. You can see here they had the PDT, and 3 years later, the cavity looks okay. This is another patient here, 55-year-old unmethylated. These are good-sized tumors, so these aren't small tumors. And then, basically shows his response after he completes the stoop regimen. Okay, so where is this going now? So right now in Europe, in Belgium and France, they're trying to figure out what light dose is effective. So one of the things they thought when they did the Indigo study in France is that the light dose they used was very low, and they feel that could be pushed up. So now they're doing a light dose finding study where they're going to look at 400, 600, and 800 joules to really kind of figure out which one is going to be the one to move forward with. So they've already gotten up to 600, and they told me they haven't seen any toxicity with this so far. We're going to launch a U.S. study, an Indigo U.S. study. It's going to be a phase 1/2, and we are going to follow in the same pattern as the French study. And we're going to start at 200 joules and then go up to 400. It'll be a 3+3 design to really understand what type of DLTs and what MTD we can define with the study. This is just a schema here, as you could see here, with what we plan on doing. So I think, the study will really look at safety and what types of toxicities in our patients. It's adding OR time. So that's one of the things we've got to think about, is that increasing our infection rate. Cerebral edema, what's going to happen there? Are patients going to have more cerebral edema? Will they require more steroids? These are all questions we need to understand as we roll this out. Is this going to also impact outcomes of patients? I mean, we don't want to do this if this is not going to make a difference, but there are some preliminary signs that it's going to be potentially helpful. So I think, I'm going to wrap it up here. I think I'm a little bit over time, but I think these new intraoperative technologies are essential. Real-time intraoperative visualization is here to stay, and I think we all have appreciated that. And I think it's highly diagnostic. It's been quite helpful for our resection of tumors. It's really the only FDA-approved agent for use in glioma surgery. So while fluorescein and ICG are being used, they are FDA-approved for ophthalmologic indications. So really, 5-ALA's gone through the full court press with the FDA. I think, the intraoperative PDT is something we need to study, and I think it's promising. So stay tuned for that. We may present more data once we get the U.S. Study rolling. Just want to acknowledge my team. Thank you.
Big presentation, and thank you. Great, encouraging. Any questions? Zach?
Costas, thank you. Always love your talks because you're always pushing things forward, which is great. I'm curious if we know how deep into the surrounding tissue 635 nanometer will penetrate.
So right now the theory is about 1 centimeter, but there may be a range of 1 to 2 centimeters. It won't go past that. And I think that's why there's a lot of groups now are looking for near-infrared agents to see if they could get centimeters into that area. The problem is you can't target the tumor as well as 5-ALA with those other agents. So it's kind of a balance, right? You have 5-ALA that kind of localizes in the tumor cells quite nicely. I mean, we have some astrocytes that take it, but those are astrocytes that are within the tumor. You don't see 5-ALA distally fluoresce in the brain unless there's a distal recurrence of GBM or whatever you're dealing with. I don't know who was. Yeah. Oh, thanks.
Was there in the PDT study you were showing those 10 patients, was there a wide variability in time of drinking the Gliolan to when they got the light therapy?
So they really try to stay with the 3-hour window. So the European label is the same, 2 to 4 hours. Yeah, they didn't change it like we've done here.
But in those patients, I mean,
they did
every glioma surgery is going to take a different amount of time to do the resection.
Yes.
Was there any trends on, we're 5 hours into taking it before they get the light versus 2 hours or anything like that?
I got to go back and look at that. I mean, from what I understood was, everyone got it within a 2 to 4 hour window.
Okay.
So, but it's a good question because maybe if you wait longer, the effect could be better. Great question. FDA won't let that happen. Yeah. And the insurance companies won't pay for it either. Yeah. So that's the other problem. Yeah.